What's going on, everybody? You're going to do a little video about assisting intubation here today. All right, so a couple of things here before I get into the equipment and we kind of proceed with the actual process of tubing this patient. You can see for RSI, our first approach is to try and get them to spontaneously hyperoxygenate. Our goal is to really try and avoid manual resuscitation until the airway is placed. We don't know if this patient's had food or anything like that, so if we go ahead and started manually resuscitating that patient at this point, we're worried about the possibility of vomit and aspiration from pushing air down into the belly. Likewise, I'm going to keep this patient positioned all the way in the upright position. I could set him up even a little bit higher if we wanted to until we actually get the drugs associated with RSI. Now, there are some exclusion criteria when you wouldn't be able to use this non-rebreather and we would have to utilize manual resuscitation. Obviously, if this guy doesn't have a stable ventilatory drive, so ineffective ventilation, not ventilated at all, or if we couldn't get his oxygen saturations up appropriately, well above 90%, we'd have no choice but to provide manual resuscitation. Sometimes if you already have an OptiFlow in the room or a non-invasive ventilator, something like that, we can utilize that as a pre-oxygenation device. We just wouldn't go through all that trouble and grab that just for this particular process. Keep in mind, we're going to be giving drugs and stopping this guy from breathing, so that's why we're trying to hyperoxygenate. We're trying to give ourselves a little bit of buffer of time that allows us not be in such a sense of urgency trying to place that tube. Couple of other things that I got going on before I get into the equipment here. You can see that I have 2 flow meters and a 50 psi Y adapter here. That's preferable. I have one hooked up to a manual resuscitator with the mask, okay, as well as one to the non-rebreather. You can get by with just one, but the problem is going to be remembering to switch over. So if you have the possibility, always try and make sure you have 2, both of them hooked up, 15 liters and ready to roll. Even though we're hopeful that we're not going to have to utilize this mask, we need to make sure you have it, all right? If whoever's intubating is unsuccessful at placing that airway, these patients are going to have drugs on board and not be ventilating. We have no choice but to provide manual resuscitation. So I got that up and rolling. A couple of other things here. Suction, obviously, is a main priority. Hopefully this is already set up in the room, but if not, you need to be able to assemble this. We want to ensure that it's fully functional. You got enough clearance here. I got a SIMS adapter hooking 2 lengths, so we got plenty of slack. For this, we're not talking about tracheal suction. We're talking about being able to suck out some nasty, thick food particles that could accumulate during this procedure if they vomit. Likewise, could have a lot of thick secretions up, blocking the glottis and obscuring our view. So we run this thing at full evac. We're going to use a Yankar in order to kind of clear those thick, nasty things that can block our view. Not 100% required, but I do like having the ventilator if I have a little bit of time, being able to have appropriate ventilator settings in, plugged up, and ready to go with just a just with a gentle little reach there, because you are going to be providing manual ventilation afterwards. Sometimes you don't have time for this and you're calling somebody else to bring you a vent, but when you do have the time, I do like to get it set up and kind of out of the way, but close enough for reach and ready to roll. If you haven't already done so like we have here, I have the head of the bed, or the entire bed pushed back from the wall to give myself a little bit of clearance. I also have, the actual headboard removed. Ours are very involved at the hospital. You just pull it out, set it down on the ground. They tend to fall over. So some of the other supplies I have set up here. The physician knows we're intubating, but she hasn't had a chance to kind of come through yet. So I just grabbed a size tube that I think is appropriate for this average size adult male. I have an 8.0 endotracheal tube. I want to go ahead and I've already done this, but I'm going to show you again. I have a 12 mil syringe. I'm going to pull that back, have a nice volume of air inside of there, firmly seated in the pilot balloon. I'm going to inflate that cuff. I'm strange. I briefly take off of the pilot balloon just to make sure that valve's not bad before deflating that, so it's ready to go. If you forget to deflate and you hand it to the doctor, they're never going to forgive you for that. I do put a little bit of kind of like a hockey stick kind of shape. We want to put a little bit of curvature on that tube rather than be straight, just to help us facilitate entry into the airway, which is a little anterior. You want to put a nice amount of lube really on the cuff of that tube primarily. That's going to be what gets hung up on your vocal cords and as we're kind of passing through. Be careful with the band. You don't want to make it too accentuated, otherwise you can actually start doubling in over on themselves. Because this thing's covered in lube, and because I'm putting it in their trachea, even though it's going through their mouth and it's not sterile, I like to leave it kind of in the package and ready to go. I also leave the syringe with air drawn back, hooked to the pilot balloon, ready to roll. I already got my resuscitator, and we talked about that. I'm going to need some means of CO2 detection to confirm we're actually in the trachea. Colorimetric CO2 is what we use a lot. You can use continuous waveform capnography, but that would have to be hooked up, you know, to whatever module or some sort of a brick or device to be able to give you a number and a waveform. This one has been exposed to room air for a long time. These generally start out purple and turn yellow in the presence of carbon dioxide, so don't let that fool you. I already have a syringe for inflation of the cuff. I'm going to show you how to check cuff pressure afterwards. A couple of the other things that we may not need, but they're good to have handy. Oropharyngeal airway that's properly sized, so an OPA. Hopefully we don't need it, but if this patient, if we don't get them intubated right away and have to provide manual ventilation, they're going to have drugs on board, very likely to get that tongue providing a soft tissue obstruction. So having that handy, hoping we don't need it is ideal. I usually keep all this stuff in a scrub pocket, so I don't always have a table here. I'm leery about setting stuff in the bed just because things disappear. A PEEP valve for your resuscitator bag, this isn't a requirement for everybody, but if you do have somebody that's got a significant amount of refractory hypoxemia, not a bad idea to go ahead and place that on the expiratory side of your resuscitator kind of ahead of time. If not, you can always pop it on afterwards. I have a commercial tube securing device, or anchor fast here, so that's just going to be once we've quickly confirmed placement, we're in the right spot, we're going to kind of keep that airway stabilized until I can kind of permanently secure that. And then also, not 100% required here, but we are going to use this once they're on the ventilator, having an appropriate size inline suction catheter. If a bunch of stuff starts coming out of this tube, going to be very, very important that we can kind of suck them out while we're able to provide manual resuscitation. Helps us not get sprayed. I got a stethoscope here as well. The other stuff that I got set up and ready for the doctor, usually we'd ask the physician what we would want or what they would want as far as being able to visualize the cords. I've already asked her she wanted a Miller tube blade, so I want to go ahead on these reusable ones, make sure you got batteries in there. This piece is just going to lock down on that bar. You hear the click. Make sure you got a nice light, and then I do close it so I don't burn through everything. I usually set that on the left-hand side there for the physician. All of my stuff, when possible, I set up on the right-hand side. That way I'm not having to reach over them whenever I'm passing them supplies and everything like that. I only have one ET tube set up. All right, I'm not going to waste through a bunch of stuff, but you need to make sure you got appropriate and very quick access to other airways as well as your difficult airway stuff. I have a lot of things on my airway cart. We got video laryngoscopy if this physician struggles getting that tube into the promised land here. Ideally, we'd have multiple other people in the room that would be able to, go fetch me supplies should they be needed. So I'm going to leave stuff on the table. Once again, clinically, I'm usually putting stuff in my pockets. I lose a lot of things in the bed, and I don't want that to happen here. So let me see if this doc's ready. Are you ready to put this tube in?
I'm ready. I got paged at my conference. I heard you need an intubation.
Yeah.
All right.
Thank you for bringing your nice stethoscope. I just wanted to make sure we'd have ability to hear some stuff afterwards here.
Absolutely, yes.
So I had this patient been spontaneously hyperoxygenating on this non-rib breather. I got suction, got you your lovely Miller 2 there.
Yep.
I decided an 8.0 tube would be the route to go. I think we got everything ready here. We're kind of short-staffed and don't have nursing, so I was
Can
the
you
one drawing
give
up
the
the
beds?
drugs as well. I
Yeah.
had a bunch here.
Yeah, let's do it.
So I was thinking we can give like 50 micrograms of fentanyl, kind of pre-treatment.
Yep.
I like a little ketamine for induction. All right.
Okay.
This patient's blood pressure is a little
Yep.
soft. I thought
Yep.
that'd be a good one. And then they're 80 kilos actual body weight. I figured 80 milligrams of rocuronium for a paralytic, and then put that in on first attempt,
All
right?
Sounds good. Mr. Jones, you're going to put you to sleep
This
here.
is Mr. Smith.
Oh, sorry.
It's okay. She's just joking. All right. Well, hang on.
All
Let me
right,
get my
you
drugs
those
out
drugs
here.
in there.
Okay, so I'm giving the drugs, so fentanyl, followed by our induction drug, so a little ketamine, and then the rocuronium. Once we get those drugs in, we're going to go ahead and take a little bit of time, about a minute here, get everything in. At that point, we're going to go ahead and lay them back.
Back down here.
At this point, too, we could go ahead and pull them forward if we needed to. You could raise the bed up so you're not all hunched
I'm
over.
actually going to do that.
Yeah, that's fine. And if you ended up, to accentuate that head tilt chin lift, you could also roll up a towel or put something behind the shoulders to really exaggerate that if you needed to. It looks like they are out here. Are you ready?
All right, let's go.
So just let me know whatever you need, and let's do this on the first attempt here, okay?
We'll try. I'm a first year.
I'm trying to kind of think about her needs here.
Suction, please.
All right, got your ink on. I got it set up where I'm handing it to her at the right orientation. She just go in. I don't know why she makes that noise while she suctions. Some doctors are strange like that. Tube?
Alright, I would like a tube. I think, would you like maybe just a little bit of cricoid pressure? Just a little
On the
bit.
patient?
Yes,
Okay.
please. Yes, thank you. I appreciate
So
that.
firm upward and inward pressure should be enough where it hurts your nose. If you put that pressure on there, you in?
I think
All right,
I'm in.
please hang on to that tube.
Hang it on.
All right, cuff is up, stylet's out. I'm gonna take the CO2 here, place that right on top of the 15mm adapter. I'm not gonna go far with my mask. All right, go ahead. I'm gonna listen here. We'd have somebody else. First, auscultation over the stomach. Oh, we're in the stomach.
No, oh,
hang on.
okay. Oh, what
So,
do I do?
wrong hole there.
Whoops.
Hang on a second. Go ahead, pull that tube.
Alright.
Let's turn them. Oh,
Ugh.
a lot of times they vomit. We got to roll them over, kind of suck some of this stuff out. Now, this patient is paralyzed and cannot breathe. Our saturations are probably beginning to fall.
Oh no.
That's why you need to make sure you got your mask and ready to roll. I'm going to prophylactically drop this oropharyngeal airway because I'm going to have to go grab some equipment here.
I'm just gonna put this tube back in.
No, I'll grab you another one,
Oh,
nasty.
oh,
I mean,
yeah, that is nasty.
Doc here.
Alright, I'll
Do you want to go ahead and grab the tube and I'll
Sure.
take care of this?
Yeah.
So I'm just going to go ahead, get a nice CE, provide some manual ventilation here, about breath every 6 seconds or so. So you don't want to grab that same tube and put it in the trachea, it's just in the esophagus. A lot of times you have a bunch of gastric juices kind of shoot up. Sometimes your CO2 detector gets a little juicy and we'll swap that thing out, but we're just playing with ours anyway, so we're good there. So I got a syringe right over here if you want to go ahead and check that cuff. I got a little bit of lube over there as well. I don't know if you had any.
I don't carry that with me.
Okay.
at all times.
Sometimes I do in my pocket.
We're good.
All right, well, you can put a little bit, I got a little bit of lube in that packet there if you'd
Okay.
like. Nice, easy breaths, okay, none of the crazy squeezing. You don't want to get this far and then have them vomit on you. And ideally, we're going to go ahead and provide manual resuscitation until we get our good
Alright.
saturations back up. These drugs are still going to be on board.
I got this. Let's try this again. Our
Split
sides
the
back up.
B with
Yep,
the tube.
Yep, I got this.
All right, so saturations are good, 99%. She's got her tube checked, ready to go. We got CO2. I think we sucked out a bunch of stuff. You ready?
Yep.
All right, so I'm going to take the bag over to my side. I'm going to pull that oral airway. Let me know whatever you need.
Suction, please.
Oh, I gave her a complex. She's not making the noise. Oh, there she goes. All right, tube.
Oop.
So I'm hoping she's going to get it in, so I'm going to go ahead and get my CO2 ready and just have it on my bag just like this on the connector side. Need a little crack?
I'm good.
That's stuck it in pretty far there.
Oh,
So cuffs up. You want to be very verbal. I'm going to go ahead. Don't give a breath until I listen over your belly here. Make sure you didn't go in the wrong spot again. Breath. Okay, nothing over the stomach. We got positive color change, so we'd be seeing that's going from purple to yellow. You want to be very verbal. All right, give me a breath every time I move. How deep are you, doctor?
Oh, 26 at the teeth.
Is that inches or centimeters?
Is that centimeters?
Yeah.
The
So we
little
got
bead.
color change, but only breath sounds on this right side here. So we know
okay.
we're in the trachea, or we know we're in the airways, but I think you went a little bit deep there, and we're probably
Okay.
right main stem. Not, you got in the right spot
Hey,
for the
hey,
most part,
yeah.
though. You just want to leave that continue to be connected and
Alright.
hang on to that tube. So what we're going to do here, I'm going to tell you when the cuff's down, and I just need to pull back. Where are you at? You said?
26 at the teeth.
So let's go back to like 20. He's not that tall. Let's go back 3 centimeters, okay? So take it to 23 once I drop the cuff.
Okay.
And I'll tell me when you're back, and I'll reinflate. So cuffs down.
All right. We're out to 23 at the teeth.
So 23, cuffs up. Let me take another listen here and reconfirm here. Oh, yeah, that's way better. So continue color change, bilateral breath sounds. Yeah, nice work. So at this point, we're going to go ahead and secure the tube. A nice doctor. I don't know what kind of mood she's in here today, but can you help me out and kind of hang on to the tube?
Sure.
You don't got anything to do? You can stay away from the conference?
It was boring.
So we take the adhesive off here, or the adhesive backing, but we're not going to on this one. I usually warm it up just a little bit. All right. You want these little plastic teeth on this this tube holding device to kind of be biting down on the tube. We'll try and get it centered here. I put a little bit of contact up above the lip with that foam, kind of push down until it sets up. That adhesive's very strong. Usually at this point you could go ahead and secure the tube. Since we're not using an adhesive, I'm going to go ahead and secure these straps. I like to be able to kind of go up over the crown of the head and above the ears, but depending on how somebody's face is shaped and how everything sets up, sometimes that's not feasible. You just want to make sure you're not like causing any sort of tissue breakdown or rubbing anything or folding the ear over or anything like that. The strap is really just a fail-safe in case the adhesive fails. I'm gonna go ahead. All right, I got the tube. I can't see the markings. Just kind of make sure I'm not moving around. We still have about 23 at the teeth.
23 at the teeth.
So there'd be an adhesive pad right there. I'm gonna wrap that around tube really firmly. Push until it clicks. All right. So make sure we're still good here. So at this point, we could really go ahead and hook that patient up on the ventilator. We're not going to, because this guy, that's how he has some extra appearing tissue on his chest right now. I tried him putting him on the ventilator. We'd hook the inline suction up. We'd get it hooked up to suction if you needed tracheal suction and turn that vacuum down. Get him set up on the ventilator and go ahead and order a chest x-ray and kind of confirm that depth. Before we do all that, I'm going to go ahead and check the cuff pressure here. So we'd like to see that cuff pressure no greater than 30 centimeters of water because we can get tissue ischemia and run into some problems after extubation. Below 20 centimeters, though, even though we might be thinking we're sealing the airway, we could get microaspiration and stuff dripping down leading to VAP. So this little throwaway cuff manometer is good for single patient use. You hit the button to kind of turn it on, get a little volume of air, usually pull back 2 or 3 mils here in case I need to add anything. Usually it's overinflated. I'm going to swiftly and deliberately kind of attach that. I'm going to look at the pressure. All right, my pressure's a little bit low. I'm going to go ahead and I'm going to add air to get, right now I'm about 28 centimeters of water pressure, which is perfect. If I was too high, I just draw back until my cuff pressure gets where I want and then quickly take it off because you can lose a little volume of air there. We get this patient sitting back up at about head of the bed about 30 degrees, clean up our mess. The 30 degrees part is for ventilator-associated pneumonia protocol. And go from there. Nice job, Doc. Hang on, I got the wrong ventilator. Can you bag for another 20 or 30 minutes? I'm going to go down to the break room.
Totally.
All right.